Our final presentation takes us into the world of supercomputing for strategic decision-making in health policy and possible other applications. To talk a little bit more about some of the exciting work happening in that arena, delighted that we're joined by Dr. Katharina Hauck, who's the Senior Lecturer at the Department of Infectious Disease Epidemiology in the School of Public Health at Imperial. Great to have you with us.
Thank you, Peter.
There you go.
Thank you. Yes, so I'm delighted to be able to tell you of some of the research that is done by myself and also by my colleagues in the area of health economics and public health. So really what the objective of our research is to inform policymakers, both at a national level in governments, but also at an international level in international organizations, how to improve the health and the well-being of populations and people all around the world. Okay, so I mean, we live in a complex world, and that also applies, of course, to the area of public health. Decisions, strategic decisions, need to be made constantly by organizations and by governments, and these decisions have long-term consequences for the policy that an organization follows, for the success of an organization, for the well-being of a population and the welfare. Now, what are strategic decisions? So they are long-term, they are complex decisions, and they are non-routine. They are usually made by senior management in an organization as opposed to more tactical decisions or more operational ones that are made at a mid or junior managerial level. Now, the main problem related really to these long-term strategic decisions is that their outcomes are affected by a high level of uncertainty. Now, there are pragmatic approaches to deal with this high level of uncertainty, and I will talk about them later. I mean, so first I think we need to understand what really uncertainty does. It will inhibit decision makers of implementing change. First, it puts at risk irreversible investment expenditures that possibly cannot be recouped when the investment was a failure. So we economists call this sunk costs in the sense of the word. Now, second, there is a natural risk aversion among policymakers because futures, managerial and political futures are at stake if a decision was wrong. Now, how practically to deal with this high level of uncertainty? One option is, it might not be the best option, but one is to postpone a decision until more information is available. So, for example, before a patient is operated on, do more diagnostic tests on him or her. Another solution is to favor decisions that can be implemented incrementally, investments that can be implemented step by step, or that can be easily reversed. So the theory of decision making calls this robust decisions, and they may be favorable even if they do not lead to the absolute optimal outcome. But often these approaches are not possible, and what do we do then? I think we need to understand more about the level or the role of uncertainty and actually what it does to our decisions. Now, the problem is that the relationship between an action and an outcome is influenced by random events, or rather by seemingly random events, because surprisingly, many systems exhibit a high level of degree of pattern in both time and space. So, for example, how the viral load in the blood of an HIV patient decreases when she adheres to her medication, or the number of weekly arrivals to an accident and emergency department, or the number of weekly cases over the course of the flu or the Ebola pandemics. So these are all things that in principle we can predict, but often we cannot. And this is then due to a lack of data or misleading data, as people who try to predict the outcome of Brexit and the American election are telling us. It's due to inherent complexity of the problem or the sparseness of the event. It's just very rare, and that makes it difficult to predict in future. Now, modeling is a way to uncover these patterns, these seemingly random processes in the world around us, and it tries to make predictions about what the outcomes of the strategic decisions will be. Now, of course, these models are always approximations to reality, and they are constructed based on existing theories and data that we get from observations or from experiments. Now, it used to be the case that in the area of health, randomized trials and experiments were the gold standard. Trials of, for example, a certain drug that was compared against standard of care. But they're often not feasible, or they're not ethical, or they're too expensive to conduct. And also, increasingly, I think, pharmaceutical companies and also policymakers find that the results of randomized trials are not generalizable in the real world. It's just too complex to try to implement a trial that replicates the real world that is around us. So what can we do then? We can then go to a situation where we use observational data. So these saw a substantial rise in my field, I think, over the past 10 and 20 years. These are collected outside of a trial setting, for example, via surveys of households or individuals as they leave, for example, a healthcare facility, or they can be patient records which are collected routinely in clinical practice, and we hope that they are in electronic form and not in paper form like here in this image. Now this, of course, goes hand in hand with a really step up in sophistication of the modeling methods that we use to analyze these data. Now, the examples of the type of methods that we are using in public health decision making and in health economics are statistical and econometric methods. Also, there are simulation methods such as epidemiological modeling of disease, of infectious disease transmissions, and also probabilistic sensitivity analysis that lets us understand the uncertainty around our predictions. Of course, there are problems with all these methods. They rely on assumptions that may be wrong, and also they require considerable time and research expertise to implement. And what they also do, they require considerable computing power. And I think this has seen a rise in the use of supercomputing in my profession, which really 10 or 20 years ago was pretty much absent. We were all happy with our desktops, but this is not really working anymore so well. Now I show you now a few examples of research that is done by my colleagues at Imperial College and also by myself. So first I want to talk about the modeling of infectious diseases, which is an example of modeling that uses the computing power of the HPC. So now I will set off here an epidemic. So you haven't really signed up for that, have you? So this, in fact, is a model that simulates the first 240 days of a flu pandemic in Thailand that eventually spread to the UK and to other countries. It was developed by Neil Ferguson from the School of Public Health. The objective, of course, is to show the likely outcome of this pandemic and how the number of cases increase and decrease over its course in order to inform them which groups of the population to screen for the disease, to give out preventive interventions or treatment. Another example is the work of my colleague Oliver Radman from the same department on HIV. So he and his colleagues use the HPC to quantify local and regional drivers of the HIV epidemic around the world. And Oliver always says he takes the view of a virus when he approaches that problem. He uses blood specimens from HIV-infected individuals in badly affected areas in Africa, and via deep sequencing of the virus establishes the genetic makeup of each virus, which differs across infected individuals. And he can then establish how similar or phylogenetically related the HIV viruses are across people living in the same region. So what he does is he constructs sexual partnership networks, or in plain language, who had sex with whom, based on how the virus looks like. He can then generate these phylogenetic analyses, which actually look quite beautiful, and of this one here, which is the HIV-1 subtype C virus in South Africa. This helps understand the progression of the disease and tailor accordingly prevention and treatment efforts. Now, some example from the work that I'm doing with my colleagues Peter Smith and Steve Martin. We have used the HPC to address uncertainty in the specification of econometric models of the determinants of life expectancy. Now, WHO received recommendations on the determinants of health and which one should be addressed to improve population health in the most disadvantaged countries. But unfortunately, the proposals ranged far and wide, covering nearly all aspects of life, from early child development to sanitation, education, and even employment. And policymakers found it difficult to actually translate the recommendations into any concrete policy. If resources are limited, we clearly cannot implement all of them. So a natural question is to ask, where should we set priorities? Which are the most important determinants of health? Now, in principle, an econometric analysis can identify those determinants, but the problem is most previous studies have analyzed determinants of health separately. So, for example, one study looked at the effect of sanitation on health, whereas the second one looked at health care. But this, of course, doesn't really help us to prioritize investments across different areas. So we adopted a slightly different approach. In order to compare all determinants, we would have needed to estimate a supermodel of life expectancy that really includes all determinants of health, which is not possible. So what we did is we split the supermodel into submodels, into over 100,000 submodels, each with just a few determinants, and we could then test the robustness of each determinant against all others, not in one go, but sequentially. So this allowed us to identify the most robust determinants of life expectancy across many alternative model specifications. Well, that's the method of model averaging. It was difficult to implement in the past because it required high computing power, but the HPC allowed us to estimate these models in parallel. Now, of the 45 determinants we tested, 20 were robust. And maybe you will be interested to hear that among the robust determinants are sanitation, primary schooling, crop production, and good governance. So we found that achievable improvements in these determinants are associated with a longer life expectancy. But the other 25 determinants, they were not robust. And really surprisingly, these included secondary schooling, healthcare, air pollution, and livestock production. So we could not be confident and give confident advice that these would lead to longer lives. Now, so the HPC facility at Imperial College allows us to estimate complex methods and address this uncertainty in decision making. The main advantage is that the simulations could be run in parallel. It's a considerable improvement in speed and sometimes means having a result in days as opposed to months. And this could make all the difference to a policymaker of whether our advice is valuable or not, because simply it would become too late. But there are some of my colleagues who use the HPC not for, primarily at least, for its computing facility, but for its capacity to store and analyze large amounts of data. Ordinary desktops just do not have the capacity to handle very large data sets. In that case, they run the normal programs like Stata, MATLAB, R that they would run on their desktops on our HPC in order to analyze their data. So, for example, many of my colleagues use patient records from English hospital trusts. Now, these are millions of records of going back 10 or so years. You can imagine require considerably memory. For example, Marisa Miraldo and Carol Proper and Eliana Barreño from the business school use this to look at the determinants of adaptation and diffusion of innovative cancer treatments. Marisa and Laure Depreux look at this to understand excess hospital admissions due to seasonality and temperature extremes. My own work, I have looked at the adverse events or medical errors in hospitals, and we calculated that it's that the health that is lost due to those is about as much as HIV and TB in the UK. And also another example, Marisa used prescription data from Finland in order to find out whether doctors are more likely to prescribe the brand or the generic version of a drug, depending on whether the patient is insured and has to pay for the medication. Yeah, they don't actually. Now, there are, of course, hurdles to the use of the HPC. We need more user-friendly interfaces. Some are scared of by the Linux operating system, so more training, I think, is needed in the use of the HPC facilities. Some statistics packages, including R and MATLAB, don't run very efficiently on the HPC. And some projects require complex workflows that at different stages require different components of the architecture, and the transfers can take a long time. Also, issues of data governance and confidentiality are obviously a big problem, particularly when it relates to patient identifiable data. Now, empirical evidence has a measurable impact on strategic decisions in healthcare more and more. Also, decision makers become more versed in the quantitative methods and demand this kind of evidence from us. An example where the empirical evidence has been used was, for example, for the essential services package in Thailand, which services should be publicly funded. We could advise the government on that. To the Global Fund, how to allocate funding across HIV, malaria, and TB in the countries that they finance. So observational data, I think, will play an increasingly role in our work, and more observational data is generated. And I think that high-performance computing, together with our research skill, will have a real impact on the health of populations and on all our welfare. Thank you.